So just before we start, just a bit of housekeeping really. Just to know that we are going to be recording this webinar because I know it's during lunchtime and a lot of people are actually doing the clinical practice at the moment and with patients. So just to say that we'll be recording this webinar just to make the resources accessible to them. Just to introduce myself, my name is Dr. Aparna Keegan. I'm a specialist in public health within the National Immunisation Office, and I'll be facilitating this webinar this morning on the children's flu program and just really talking you through the program itself. We've also got with me Dr. Eimear Hayes, who's the SMO within our National Immunisation Office as well, and Cría Dowling, who's one of our communications leads and supporting the flu vaccination program this year. We've also got Dr. Alice Quinn, another SMO from the National Immunisation Office, and Alice will be kindly answering some of your questions and managing the chat room as we take you through this webinar. So if it's okay with everyone, we'll get started if that's okay, because we've got quite a lot of things we're going to go through this morning, including talking about flu in children, around the background to the NIO program, about why we're encouraging our primary care partners this year to go into schools this season. We'll also be hopefully hearing about the experiences of going into schools this season by one of our GPs, Dr. John Foster, who hasn't managed to join us yet, but we're hoping that he will be able to come in through as well. Then we'll be talking a little bit about the frequently asked questions from healthcare professionals, and then there'll be an opportunity for you to answer any of the questions that are coming into the chat. And lastly, if we have time, we'll go through a little bit about the theoretical aspects of the vaccine itself, including dosage, administration, contraindications, and ordering. Although those areas have been covered in previous webinars and they're also available on HSE Land. So next slide, please. So just talking really about flu in children. So the World Health Organization recommends that children under 5 should be offered the flu vaccine, and that's because they're a really high risk of flu illness and also complications as well. And complications you're probably quite familiar with of flu. The ones being bronchitis, otitis media, sinusitis, and secondary bacterial pneumonia, but less commonly associated, but also really important to remember are the significant complications, for example, meningitis and encephalitis, and also primary influenza pneumonia as well, which can be quite debilitating for young children. Next slide, please. So it's worth noting that 1 in 10 children under the age of 15 actually attend their GP with influenza-like illness each season, and the rates of flu are particularly higher, in younger children, leading to excess doctor visits, hospital admissions, and antibiotic prescriptions as well. And children under the 5, in particular, are highest risk of complications. And if you look at the graph on the right, the age-specific rates of hospitalization are very high in the under 5s, and as are the critical care admissions as well. Next slide, please. So our colleagues in HPSC had a look at in terms of case rates and the burden of pediatric flu for the Irish health system over a 10-year period. We haven't included the COVID period because that's slightly, I suppose, because of the COVID restrictions, the data would be slightly different. So looking at the 10 years from 2009 to 2019, there were 11,000 cases of confirmed flu in children. Just under 5,000 were admitted to hospitals. Around 180 were admitted to ICU requiring intensive care. And unfortunately, there was also 41 deaths. And it's also worth noting that behind every one of these numbers that we're talking about here is a person, is a child, and there's also a family involved as well. So if you go to, for example, websites like Families Fighting Flu, you'll be able to hear some of these the stories of parents, particularly in terms of the children who have no underlying health conditions, who have had a devastating impact of flu, and unfortunately some deaths as well. So it's really important to remember the people behind the numbers that we're talking about today as well. Next slide, please. So it's also important to remember that children in particular also transmit flu for longer as well. So for 10 or more days when compared to adults, which is around 6 days really. And also it's important to remember that daycare centres and schools are important transmitters of flu to the community because particularly they're meeting with teachers and also younger children in the care of grandparents, etc. So they really are able to be, what we call super spreaders. So really important to remember that as well. And particularly with younger children, in terms of maintaining respiratory hygiene, can be more difficult as well. And again, being a risk factor for transmission as well. Next slide, please. So I just wanted to talk a little bit about the flu activity that we're seeing this season. So HPSC, our colleagues in surveillance, released weekly surveillance reports that you'll be able to find on their HPSC website. And the latest surveillance report shows that there's been so far 828 laboratory confirmed flu cases in Ireland this year. So there's definitely flu circulating. 36% of these cases were reported in hospital inpatients. There were unfortunately 11 critical care admissions as well. And there were also flu deaths. So this is not in children per se, but this is just overall. They don't report breakdowns by age, for particularly for small numbers, just in terms of to ensure that there's no patient identification, etc. A lot of the cases that we're seeing at the moment are flu A cases. One thing to consider really is that HPSC have also sent out to all of our GP colleagues and our pharmacy colleagues about the antiviral notice as well. So you might have received that from our HPSC colleagues. And that's because HPSC are considering that flu is currently circulating. When we had a discussion this morning at the National Flu Steering Group, actually, what you'll notice at the graph on the top there, you'll notice that flu rates in red this year are actually going up earlier than expected. So earlier than last year's flu season and also from the previous years as well. And what they're also seeing is that it hasn't taken off as a sharp curve. So there is a bit of a lag there coming up slowly. So at the moment, there's a lot of RSV circulating as a lot of frontline healthcare workers. You'll notice that coming in, particularly with younger children. So what they are saying is that there is a golden window of opportunity in the next couple of weeks before flu really takes off, that we actually vaccinate our children during this period and get them protected, adequately covered before flu cases really take off. And it's also worth noting that flu is widely circulating in Europe at the moment. In other countries, for example, Portugal, Germany, you may have seen some of the reports from the UK as well about children's flu and their emphasis on that as well. And it's worth remembering that, COVID is still circulating and that added burden of both, COVID and flu. And I think we've seen in reports at the moment, they're calling a triple epidemic of, flu, RSV, and COVID this winter. So it's really important from that perspective. We are covering our children early this flu season with the vaccine. Next slide, please. So I'm just going to give you a little bit of a background in terms of the flu vaccination program in general. So the LAIV or the live attenuated influenza vaccine, the nasal spray flu vaccine as it's called more commonly, it was first licensed in 2003 and millions of these doses have been given to children across the world, including in countries such as the USA, Canada. It's also worth noting that in the UK and Finland, the children's flu vaccine is given as an annual program as part of the seasonal flu vaccination campaign program for them. And in the UK in particular, it's been part of the program since 2013. And in Ireland, we started in 2020. So we started with children aged 2 to 12 years old. And then the 2020 season is expanded to 2 to 17. Last season, we went for the full cohort, which is 2 to 17, and we continued that this season as well. Next slide, please. So we get quite a few questions about, I suppose, about the effectiveness of flu vaccines. So it's worth noting that, in some studies, the children's flu vaccine and the nasal flu vaccine in particular has been shown to be more effective compared to the inactivated flu vaccines that adults get. So this is because the LAIV contains a live attenuated viruses and it mimics natural infection. So it creates a more durable immune response and a longer term protection for children when compared to the inactivated vaccine. So hence why it's the preferred vaccine in our children aged 2 to 17, unless of course they have a contraindication. It's also worth noting that the nasal flu vaccine also offers protection against some strains that are contained within the vaccine as well. So some strains that have got antigenic drift as well. It's worth noting that flu vaccine effectiveness can vary by season. So and I'll go through in a bit about why that is. But the data on the right is actually from our colleagues in Public Health England. Looking at flu vaccine effectiveness over a number of seasons, as you can see, can be variable. For example, in 2016-17, there's about 66% effectiveness there that was recorded. Some seasons, for example, 2017-18, it could be slightly lower. For example, there's 28% there. But really, it's important to remember that even if the effectiveness of the flu vaccine in preventing illness might be lower in some seasons, it's worth noting that a flu vaccine can prevent complications. So even if they do get flu, they're less likely to have severe complications from it. It's important to reduce hospitalization and also the admissions to critical care as well. So that's why our number one message, I suppose, when you see us in the media or talking to people, we always say vaccination is your best protection against flu. Next slide, please. And I suppose just to understand a little bit about why the flu vaccine effectiveness can vary. So this is actually a slide that's taken from the Oxford, the vaccine group, and they have a vaccine knowledge project there, which really is helpful for healthcare workers, when they have questions, and it helps understand, and they have really good graphics to share with patients as well. So it's just really to understand that the flu vaccine is a complicated virus, and you can undergo changes very quickly. And what we do find is that the WHO, based on the data, surveillance data that's coming across the world, they try and feed in 6 months beforehand what are the flu strains that should be covered for the upcoming flu season. So that's how the decisions are made about the upcoming flu season, and that's why we recommend that there's a flu vaccine for every season, so that people are, covered for the latest viruses that are circulating. It's worth noting that 9 out of 10 years, the vaccines actually match the strains that are causing the illness. So it's really important and very good, I suppose, protection from that as well. Next slide, please. And really to talk about the aims of the program itself. So we talked about the impact on children. So the flu vaccination that we're offering to children is to reduce the morbidity and mortality associated with flu. It's also to reduce the number of people with flu, the number of hospital admissions. We also talked a little bit about the impact it has on transmission. So really we're hoping that by protecting children, you're also indirectly protecting the elderly and also people in risk groups as well. It also reduces risk of transmission to healthcare workers in families with children, and to reduce the absenteeism in children from school and also parents from work. And we all know that COVID had such devastating impact on our children in terms of their social mixing, going to school. We don't want to impact that any further. So really having that flu vaccine is protective against that. And it's worth noting that this year, although the target should be 75%, and I'll show you in a reason why we've selected the 40% target as a modest target that we're aiming for this year for the program. Next slide, please. So just to talk a little bit about vaccine intentions, this is based on surveys that we've done of parents in Ireland. So this is the pie chart on the left actually in particular shows the survey that we did with a number of nearly 2,000 parents, I think it was, in 2020, to ask them about what their intentions are to get the flu vaccine. And an overwhelming majority, 48%, actually said that they would be interested in getting the flu vaccine, and around 23% said they're not sure. So these are the groups that would be amenable to information from healthcare workers, in particular positive messages, to give them the information to make an informed decision. And as always, there are some parents who are very sure they don't want to get the flu vaccine, and that lies about we think around 28%. So the don't knows are the 23% who'd be amenable to messaging. But it's really important to remember that 48% are strongly convinced that they do want to get the flu vaccine. Also did a survey as well with a smaller focus research group with our communications team. And it's worth noting again, it reflects that only a third of patients there are showing that they don't want to get the flu vaccine. And they've highlighted a number of reasons why they didn't want to get it. And I think it's important to understand and respect those wishes, but it's also important to understand what those reasons are. And I think the number one thing is that risk of perception that, the flu is not serious for their child. And we know that flu can be serious. It can be a serious illness for some children. So it's really important to get those messaging across to members of the public as well when we come into contact with them. And there are some, as I said, who don't agree with the flu vaccine, who may be concerned about the safety. And it's worth mentioning, that we do have some resources to help healthcare workers talk to parents about this. But again, it shows that, one third, yes, they may not want to get the flu vaccine, but there are two-thirds of parents who do want to get the flu vaccine for children, again, reflected in this survey. So how does that translate into vaccination rates? So just next slide, please. So really, I'm just taking you through the uptake rates for this season. So just shy of actually the rates, when I looked at it this morning on our dashboard, it's just come up over the 100,000 mark. But still, that's about 9% of the cohort aged 2 to 17. Again, very low uptake. Slightly higher if you look at the bar chart on the right in terms of numbers, slightly higher number in the younger age groups who are getting the vaccine. This is reflecting on previous seasons as well. The other issue that we're seeing is that there's quite a wide variation, I suppose, across the regions as well. For example, some areas like Carlow, Cork, and Dublin, we're seeing higher uptake rates in their age group, but some others like Leitrim, Donegal, and Monaghan, we're seeing very low uptake rates in the children's group as well. It's worth noting that the children who have been vaccinated so far, 61% have had it at their GP and 39% at their pharmacy. So just a quick whistle stop tour on uptake this season. In the next slide, you'll see the uptake in previous seasons. So this is done at the end of the seasons. Again, not spectacular uptake rates. There's a number of reasons for this. And I think one of the key things, as we mentioned before, is that parents do want to get their children vaccinated. So at least 50% do anyway, based on the survey that we've seen earlier. But this is not translating into uptake rates, right? So, for example, we've seen in the last season, the uptake rate, particularly for younger children, if we focus on the 2 to 12 age groups, because we are really concerned about the younger cohorts for the flu vaccine, we're seeing 18.8%. And that's actually a drop from the season that was introduced, which was 2020-2021 season, where the uptake was 29%. And also, it's worth noting that there is some modelling work done by Bagwino et al., where they suggested that you should at least see a 30% uptake rate in terms of universal vaccination to be able to see that benefit in children and also that population level benefit that we're hoping to get from the flu vaccination program as well. Next slide, please. And just really quickly, so we've seen that flu vaccine uptake rates aren't great, in our flu program this season and also in the previous seasons actually. But we know that parents want to get vaccinated, so we're trying to think about what can we do to try and increase uptake. And we've done a number of things this season in particular. So we've done things like the pharmacy finder service to enable parents to find a local pharmacy to get their flu vaccine. We've also released toolkits as well to enable GPs and pharmacies in particular to go into schools and work with our partners on the ground. We've also written letters to schools, school principals as well. And one of the key things that we thought about doing is, well, we have done actually last year, is pilots. And these are based on flu pilots that were done in England. And you probably know that the flu vaccine is actually offered in England to children in primary school, in school itself, since 2013. And this data was actually based on pilots that were done earlier on in time. So the pilots actually happened in 7 areas, and they found that through these pilots, the uptake actually increased to 52%. And you'll see that actually when they compared it to areas where they were just offered inside, a GP or a pharmacy, the uptake was much lower. So it actually increased from about 27% to about 55% there. And it's worth noting that in particularly, it's quite effective when they're reaching out to primary school. So there is a bit of a difference there in terms of the primary school and secondary school. And there's also an association with ethnicity and deprivation. It's also worth noting that in particular, I think school-based approach really does impact on equity as well. So it's really positive in that sense that all children are afforded the opportunity to get the vaccine by offering it through the school-based approach. It also the pilot also showed there's an increased coverage and also had indirect impacts on the population level as well. Through these pilots, they also talk to parents about vaccine hesitancy and what's been impacting on that. And the main reason that some of the parents quoted as not having the vaccine, even when it was offered in school, was a lack of awareness of the importance of the vaccine, and that was again reflected in our survey that I mentioned earlier on. They've also talked concerns about the vaccine effectiveness, about the side effects, and particularly in England, I suppose there are some religions where Paul Sanjantin is an issue, for example, or the Muslim population. So it's just really, they did a lot of work going to the imams and the local mosques, etc., getting statements to talk about, the importance of the flu vaccine. So it was very important work that was done in the UK there. They've also taken similar approaches in Hong Kong, where they've done pilots in Hawaii statewide, and also in New York in some of the schools there. And consistently, I suppose, the evidence has shown that school-based delivery really does improve uptake. And the next slide captures some of the successes from the flu pilots in England. Just to also mention, when I had a quick look at their data for uptake last season, when they delivered it through schools, in primary school, the uptake consistently has remained around 60% there as well. So from the pilot data, it shows that there was a 96% reduction in GP ILI consultation rates in the pilot areas. A&E attendances were 74% lower as well. Hospital admissions due to flu were also significantly lower. And it's worth noting that there's also a reduction in adult influenza-like illness consultations as well within the GPs. And I think that's really important. As you probably know, in primary care, we are seeing a lot more people coming in with respiratory illnesses. So it's really important to protect our health and care system this season. Next slide, please. So what we decided to do on the back of that really as an initiative to improve uptake, we actually undertook some pilots last season. So we did it in a very small scale because there was a lot of work going on, I suppose, with the teams on the ground. So 3 areas, CHO 3, 7 and 8 agreed to take part in the pilot. The aim of it really was to see what impact it had on a local level, whether it was translatable to an Irish context, and also the feasibility as well, just to look at, what is the impact on resources, etc. The next slide, please. So in total, the 3 schools, there was about 200 children in each of the schools that were targeted with the initiative, and they were, quite distinct geographic areas as well. They were provided with, information leaflets, consent forms, and template letters that the local teams adapted and circulated to parents. The immunization teams then sent the parents the consent forms, and they received those back. They had to review the consent forms, and they also followed up with a small proportion of parents any questions that they had with regards to clinical details on the consent form, for example, about allergies, etc., that they weren't unsure of before the vaccination happened. So once they had reviewed the consent form, they knew which of the kids who were supposed to get the vaccine. There are a small number who couldn't get the vaccine, for example, those with contraindications, or those who they knew would probably need a second dose. So with regards to their decision was made beforehand, and I think that really helped them before they got onto the site as well. Next slide, please. So the results really was that we saw a significant increase in uptake. So the pilots actually took place in late November, early December last year. So there was a significant amount of time for the parents within those pilot areas to actually go to their GP and pharmacy and get the vaccine naturally, I suppose, through the routine program. And the uptake at that point in time, only 12.4% of the kids in those schools had actually got the vaccine through the GP and pharmacy route before they were offered it in school. And when they were offered it in school, actually, the uptake overall in that school cohort increased from 12.4% to 76.3%. And also, we noticed that only a very small number of children who were offered the vaccine had contraindications, 4.9%, and less than 1% required a second dose of the flu vaccine as well. And not surprisingly, around 17.5%, so 1 in 5 parents, actually refused consent for the flu vaccine. And that's not, that's in keeping with, I suppose, our earlier studies that we've seen on surveys with parents. We were also interested in terms of vaccine wastage because we supply the vaccines to the teams. Around 66% of the vaccine was used, and the other vaccine, they actually kind of worked with their local partners on the ground with primary care to distribute the vaccines, I suppose. Next slide, please. And it's worth noting that, the resource implications, because that's the other thing that we were interested in, I suppose. It does take more effort to go into schools, but I suppose the benefit is that you get a larger catchment of children and you'll be able to do it in a faster period of time, a larger volume of children vaccinated by reaching out into schools. Um, so it depends on how many staff they took with them. So if they took with them more staff, naturally they were able to do more vaccinations and spend less time and were more efficient on the ground. On average, they took about 2 to 5 minutes. I mean, those of you who've been doing the flu vaccinations for children already, you'll know how fast and quick it is. But I suppose it's the observation time after as well. They need to be observed after. But some teams did say, it does take 10 minutes per vaccination, particularly if you're inputting all the data into the immunization system or PharmaVax or GPVax or your duty practice management systems. So there is a bit of time to consider there. There is also a bit of staff time to consider before and after the session. For example, administrative time to deliver the consent form to schools or linking in with school principals to organize the event, and also data inputting if you're retrospectively inputting it into your systems afterwards. So just a bit of time noted there as well. Next slide, please. So key learning. So we actually did an evaluation of this pilot from the sites with the people who were actually delivering the vaccine to, I suppose, to the children. So really key learning was early start. So they really wanted to make sure that they had an early start because there are also school immunization teams who are dedicated to the program that are going into the junior infants vaccination program, so not to clash with the schools then. And also they said that they found that the nasal spray flu vaccine in particular was, an easy administration. There was no issues with that. A key success factor really is having that support from the school as well. If the schools were supportive and enthusiastic about the program, it really helped accelerate the program there. The one team reported that there was consent form difficulties for some parents because it is a live vaccine. There are more contraindications to go through. It can be a considerable form for parents to complete. So we had a quick look at that when we released the consent form again this year. Unfortunately, there wasn't much we could do with that because we felt that we wanted the clinical details there within that. The next slide, please. There was also requests for additional resources. For example, they wanted more, they felt that they wanted more clinical and administrative staff to support this process. I think one of the key learnings from that. And they wanted electronic systems being developed for this. So I know that this year we took that on board and pulled in flew into COVAX. So it's following a similar pathway to the COVID program just to make it simpler for everyone because we know that we'd like, co-administration particularly to happen for the older age groups. They also had a suggestion for electronic consent forms. We're not quite there yet, but it can be considered for the future, I suppose. And the other thing to remember is, as I mentioned before, the contraindications and those who need a second dose, just thinking through what the pathway for those small number of kids would be like. So that was the key learning really on that. Next slide, please. We also surveyed the parents as well of this. So 38 parents actually responded back and told us what their thoughts were. An overwhelming majority were very happy, 95% were very happy with the process. The UK pilots also did a survey of parents, and an overwhelming majority there as well were in favour of the school-based vaccination for flu because of the convenience in particular, as you can imagine, for working parents. And how it motivates children as well. When they see their friends get the vaccine, they feel fairly happy that they wanted to get the vaccine as well. So really, that was the main survey results from the parents that we've seen. Next slide, please. We also had a quick chat with the school principals in one of the schools, and they were very happy with the program as well. And we've actually this year we've had a number of schools actually contact us directly to say, is it possible to do this on a larger scale? Next slide, please. So we also did a quick survey because I know a number of pharmacies reached out to us as well last year. So we did a survey and we showed them the the material that we developed for the school-based pilots, and that's what gave us the idea this year really to encourage GPs and pharmacies to go out into schools. Was the initiative taken by some of our community providers to go into schools last year. So we gave them some of the materials we developed for the pilots, including the consent forms, because we had them. We said, feel free to use those. And around 14 pharmacies, replied back to us and said, we've gone into schools and this was our experiences. 8 had gone into the schools, and one of them actually had parents attending the pharmacy, so they had dedicated clinics, I suppose, for that school setting. And they'd mostly gone into primary schools. Some of them had also gone into secondary schools and also childcare settings and community groups as well. So using a lot of initiative to think about where children and parents would be to offer the vaccine to them on site. And uptake rate, this is obviously self-reported uptake, could range from about 30 to 90%. They found that particularly the use of our HSE materials very useful, and hence why we created some of those dedicated materials this year as well. So the key learnings for that was, some of the pharmacies had dedicated online consent forms, so they had their own processes for making this easier, earlier availability of the option for the inreach, and hence why we listened and learned from that this year and said, we start from the start of the program, and also support from teacher and parent groups, as we heard from earlier as well. Next slide, please. So we had a number of tools that we released for this year to enable you to go into into the school settings for both GPs and pharmacies. So we have this toolkit on the left that's there to talk about how you engage with schools and child-based settings. We also have consent forms in the middle over there, both in English and Irish. And on the right, we also have a new toolkit that's available on our website more recently to talk about other initiatives that you can do, so beyond just schools. So really thinking around how do you talk to parents, what are some of the key facts and figures, and what's some of the evidence-based ways to improve uptake. So those are all available on our immunisation.ie website. Also on that website, you'll probably know this as well, there's a number of other resources, including frequently asked questions on the flu vaccine. So hopefully you'll find that useful as well. Next slide, please. So I'm really pleased to next invite Dr. John Foster to share his experiences this year with the Children's Flu Programme. Dr. Foster, please.
Hello. I'm having a little bit of technical difficulties, so I'll try and continue as best I can. So we are a GP practice based in Rush in North County Dublin, and this was our 3rd year going out to schools. So initially in year 1, we had one school, and the reason we were able to get in there was that our practice nurse was actually on the board of managers, and she had asked us if we could facilitate the nasal flu vaccine for the kids in the school. And that was in St. Catherine's School in Rush, and it was around about a 50% uptake that year. The 2nd year, which would have been last year, again, we had reached out to other schools in the local area, but it was only St. Catherine's School that accepted the sort of the invite again, and there was a slight increase in the numbers, but it's sort of still in and around the 50% mark. This year we've seen a fairly significant uptake in the flu vaccine, so we had reached out to all of the primary schools and some of the post-primary schools in the area, and we had 3 schools come on board this year. We had St. Catherine's, St. Brendan's, and we had Rush National School as well. So with St. Catherine's, the numbers had remained fairly similar, about 140 out of about 300. Now there were quite a few absences on the day. In Rush National then, we were at about 55%, and St. Brendan's, which is a smaller local school, we actually managed to hit 77%, which was a fabulous uptake there. There was a number of things to consider when we looked into this. I suppose we had the benefit of having this being our 3rd year. We were familiar with the process, and we were able to then take the sort of the systems that we had in place and transfer those to the other schools. So I suppose the first thing then is to consider would be the logistics of it. And what we did was we sent an email to the school introducing ourselves. As I say, 3 schools then came back to agree to allow us to come in and to vaccinate kids in the school. Then the school sent an email out to all of the pupils introducing ourselves as a local GP.
Setup mode is off. Just a moment while this device reconnects.
We sent an email then. An email was sent by the school introducing ourselves as the local GP practice, that we would be offering the nasal flu vaccine, and that a lot of the schools use apps now. So the one that the local schools seem to use is an app called Aladdin, and as part of that they have a permission, and I think it's used for school tours and walks and things like that. So any parents that were in agreement then responded to the permission slip on the app. Then the school sent the consent forms out. And again, at this stage, we were able to identify anybody that was maybe contraindicated for the nasal flu vaccine then. So again, we were able to use those numbers then to gauge how many vaccines to order from cold storage, and then again to gauge how many staff members to bring with us. So I suppose again that is something else to consider as well, is medical staff time, nursing staff time, and then, as you'd highlighted yourself, Dr. Keegan, then the administrative time as well, which for ourselves we found was really the biggest issue here. It wasn't the administration of the vaccine. It's a very easy vaccine to give. It was the inputting the data into Socrates, for example, and then sort of uploading the data then. And I suppose the other issue we found as well then was that because they're not necessarily our patients, we then had to set up temporary patient charts for each of the children as well. So there is a fairly significant time, administrative time involved in it. You'd mentioned as well, so we were given this school's use of the apps. We were wondering, is it possible to use a sort of a digital signature? Now, among ourselves, we decided that it was best to have sort of a written signature that we then could scan to our charts, that we had a record of it. And again, given that these aren't necessarily our patients, that we had something to go off of in terms of medical history, any contraindications and things like that, and that we had a copy of the signature on our own systems as well then. So overall, our experience this year has been very positive. The 3 schools were keen to kind of see that we were coming back the following year. We'll continue to reach out to the other schools in the area. The experience itself was very positive. Any staff members that came out with us really enjoyed their time. There's a really nice atmosphere in the schools given the vaccines. And it's something we would be very keen to continue with in the years to come then.
Brilliant. Thank you very much, John. Can I just ask, John, in terms of being on the front line, are you seeing a lot more cases of children coming forward for with respiratory illness this season, particularly? I think RSVs, we've heard that it's really on the rise, particularly younger children.
So certainly my own experience would be that yes, we are seeing a rise in the number of respiratory presentations. And I suppose the other thing that we would notice as well is that they seem to be lasting longer as well. So sort of with bronchiolitis and things, they talk about the classic sort of 10-day presentation, and things do seem to be lingering a little bit longer this season as well. So we're getting second and sometimes even a third presentation with the same illness as well.
Gosh, the other thing I wanted to ask, John, was the schools that you had attended, I suppose. What size schools were there, and approximately how long did it take, I suppose, to kind of complete a round of vaccination for the children in that school? How long would you say is the timing?
So I have the figures in front of me here. So Rush National School has approximately 740 pupils. St Brendan's had 110, and St Catherine's had about 300 pupils. we actually did all of them sort of after the morning surgery, sort of between the end of morning surgery and over lunchtime as well. And so we were able to get them done quite quickly. Again, our practice nurse was very proactive, being involved with one of the schools. So it was a couple of weeks from the start of the process, getting everything sorted out, and to getting into the schools and getting the vaccines administered then.
Brilliant. Thank you very much, Dr. John Foster. I'm not sure if there's any other questions that are coming up in our chat bar. Alice, are there any questions coming up for Dr. Foster from our...
I don't see any there at the moment, Aparna.
Brilliant. Thank you very much, Dr. Foster. Great. So we'll go back to our content, if that's okay, to our presentation. So I'm just going to hand over to Cría just to talk about some of the other resources that we have that hopefully you're already aware of. But yeah, over to you, Cría.
Thanks, Aparna. Just to talk to you about the communications campaign and resources available for vaccinators. As you may know, that the flu vaccine campaign launched at the beginning of last month in October, and will be ongoing until the end of the flu season next year in April. The HSE flu vaccine campaign aligns with the overall winter vaccinations campaign, encouraging people to top up their protection and get the vaccines recommended for them this winter. Our communication is focused on the key target groups, so children aged 2 to 17, their parents and guardians, at-risk groups, including those who are pregnant, those with certain long-term medical conditions, and people aged 65 and over, and of course, healthcare workers. The objectives for this year's campaign include achieving the target uptake for the current flu season, giving everyone who can get the free flu vaccine the information they need to make an informed decision, and positioning the HSE as a trusted source of information. Just to demonstrate the importance of communications and the impact our campaign had last season, so we surveyed parents, and the ads for the children's flu vaccine performed quite well last season, and resonated strongly with our target audiences, so parents and guardians. As you can see, parents found the ads very informative, and the messages were clear, and they had a lot of trust in the information that was presented in the ads, and it was relevant for them, so they had the information they needed to make an informed decision. And there's also high engagement across the ads as well, so people enjoyed it and it resonated with them. And this all contributed to encouraging intent and action among parents, with 3/4 of them saying they're more likely to consider getting the vaccine after seeing the ad. It's just really the importance of communications. And just to briefly highlight some of the resources that are available to you on the HSE website, hse.ie/flu, and the NIO website, immunisation.ie. So we've our 2 modules on LAIV available on HSE Land, and we've also a number of information materials, including algorithms, one specifically for LAIV, and also patient leaflets and posters. Just to also mention that we, Aparna touched on it briefly, we have the toolkit for GPs and pharmacists on increasing, tips on increasing uptake for the children's flu vaccine. And we also, new for this season, is a toolkit available for GPs and pharmacists on how to use digital and social media to encourage uptake. So things like how to join the HSE Pharmacy Finder service that Aparna also mentioned earlier on the HSE website, optimizing your Google and your social media profiles to reach your audiences more effectively. So using things like Instagram and Facebook stories, and also some sample social media messaging and assets that are available for you to use also in English and in Irish. So now I'm going to pass you on to Dr. Patrick Kelly, who will be discussing the frequently asked questions that come in to us from healthcare professionals about the children's flu vaccine.
Hi, thanks very much. Can you hear me?
Yeah, we can hear you, Patrick.
Great. I'm not sure if you can see me. I'm currently out vaccinating, so apologies. So if you just go to the next slide for me. So a common question is, can you give the flu vaccine with other vaccines? And the answer is yes, you can. And that is with the exception of the PCV for children aged 12 to 23 months. So it's okay to give the flu vaccine at the same time as you're giving any other vaccine, but the advice is that you give it in a different limb because we're not, particularly with COVID-19 vaccine, because we're not sure about the reactogenicity, and that refers to the immune response that you have after you receive vaccination. Next slide. So it's really important to check the expiration date of the nasal flu vaccine. When it's made, it has a valid period of 18 weeks. So the expiration date is written on the side of the nasal applicator, and it has a day, a month, and a year. And you can administer the vaccine up until that particular date. So it's important to know that it may not be the end of the month. So if you see February on the vaccine, that doesn't mean it could be the end of February. It may mean it's the 12th of February. So it's really important to check that. Next slide. So what happens if you have a problem when you're administering the vaccine? So common things are, the kid has a snotty nose or they sneeze. If you've administered the vaccine, it's not required to give an additional dose. If you've only given it into one nostril, it's not required to repeat it. There's enough viral particles in it that it will induce an immune response. I think I've covered everything there. Yeah, so if you go to the next slide. So if someone is immunocompromised and if a child is living with someone who's immunocompromised or severely immunocompromised, is it okay to give the vaccine? So the NIAC guidelines say that, or the advice is that children who live with severely immunosuppressed persons requiring isolation, such as those who've had a stem cell transplant, should not receive the quadrivalent live attenuated flu vaccine. However, that's only a precautionary measure or precautionary advice. In the US, over 10 years, millions of doses of LAIV have been given to people who live with people who are severely immunocompromised, and it has never been known that someone who was immunocompromised has come to harm. So ultimately, at the bottom in the bold writing, it says any child living with a person who is immunocompromised by treatment or disease may have the LAIV vaccine, unless that person, which is the person they're living with, has to live in total isolation at home. So it's unlikely that you will not be able to give someone a vaccine if they're living with someone who is severely immunocompromised. Next slide. So in relation to egg allergies, it's okay to give the LAIV vaccine to someone who has a confirmed egg anaphylaxis, as long as they've not required admission to ICU. So if you're in the community or if you're in school, it's okay to give the LAIV to someone who has a known egg anaphylaxis, as long as that egg anaphylaxis did not require an ICU admission. In fact, LAIV is the preferred vaccine for children who have required admission to ICU for a previous severe anaphylaxis to egg, because the intranasal route is less likely to cause a systemic reaction or anaphylaxis. However, that vaccine obviously should be given in the hospital setting. And for those who require a non-live influenza vaccine, who've had a previous ICU admission for a severe egg anaphylaxis, you should get a specialist assessment. So you may want to contact, depending on where you're living, different regions will have different avenues for advice. So it might be a local pediatric department, or it might be your community health office, but GPs will know where they get that advice locally. Next slide. So the adverse reactions, they're pretty much the same to most other vaccinations. Because it's given intranasally, a lot of people are going to get nasal congestion, so that's quite common. Then the other side effects that are common after vaccine, so fatigue, decreased appetite, headache, muscle aches and pains, fever, and these things are generally mild and resolve within a few days. Some people may ask about Guillain-Barré syndrome, which is an ascending paralysis. And certainly some parents have asked me about that in relation to COVID vaccine. However, it is very rare, and there is a greater risk of having Guillain-Barré if you've actually had influenza compared to influenza vaccination. So if they're worried about that, it would be good to point out that they're more likely to get Guillain-Barré if their child gets influenza. And next slide. So after vaccination, it's recommended for all vaccines in Ireland that you observe someone for 15 minutes, and that is on the very rare possibility of anaphylaxis. If it's not practical to observe them physically, then they should remain in the general vicinity. So they might be waiting in a lunchroom or in the car outside, but they're nearby to you if something goes wrong. And then, of course, it's important to have the necessary drugs, equipment, and protocols if someone does suffer anaphylaxis. And there is a anaphylaxis protocol for medical settings, and there's an anaphylaxis protocol for the community, which you can get on the NIO website. If someone does have a vaccine reaction or they report feeling unwell, either you as the healthcare professional or the patient can report the adverse reaction to the HPRA. And we do appreciate when people report this because it's all to do with kind of medication safety and pharmacovigilance. And I think it also reassures patients as well that we are recommending them to report side effects because it builds confidence in the vaccination program and with medication in general when patients realize that healthcare workers are saying, well, we'd like you to record that. I think that's the last slide, but you can go to the next one. Yep, that's great. Thanks.
Thanks very much, Patrick. So I don't see any other questions. Are there any questions coming up, Alice, in the chat?
Just Ola Pa was just asking, could she get these presentations emailed to her? So I'm sure that's possible. We'll just check with Cría there.
Yes, so what we'll do actually, Ola, is we'll actually upload them onto our website, so you'll be able to download them. We'll share the link together with all of the resources we mentioned so that everyone has access to it, together with the recording as well, just to make it easier. If that's okay, I might move on to Eimear, just to go through a little bit about the background in terms of the dosage, etc. As I said, this information we've gone through previously, but I think it's just worth having a quick refresher if we've got a couple of minutes. Yeah, could you put up the slides again? Oh, great. Thank you.
Okay. Great. So I'm just going to talk a little bit about the LIIV vaccine, just as a refresher. I'll try and be as quick as possible. So regarding which vaccines are recommended by age, the 2022-23 season HSE seasonal vaccination program is offering the quadrivalent live attenuated influenza vaccine, which has a nasal application for those aged 2 to 17, and the brand available is the Influenza Tetra nasal spray suspension influenza vaccine, which is a live attenuated vaccine with a nasal application manufactured by AstraZeneca. There is also the inactivated quadrivalent influenza vaccine known as the QIV, available for all other eligible populations, including those who are aged between 2 and 17 who have a contraindication to the LAIV. QIV is licensed for anyone aged 6 months and older. There are 2 brands of injectable vaccine which will be distributed and are interchangeable where 2 doses are required. So the quadrivalent influenza vaccine split variant inactivated, manufactured by Sanofi Pasteur, and the Influvac Tetra marketed by Mylan. And thanks. Can you do the next slide? Thanks, Cría. So the Influenza Tetra LAIV vaccine is supplied in a box with 10 single applicators. It's a pre-filled nasal applicator, and each applicator contains 0.2 mils of nasal suspension. It's ready to use. There's no need to reconstitute or dilute. It's pale yellow, clear to opalescent. Small white particles can appear in it. Next slide, please. Thanks. So how many doses of LAIV are required? So in the license documentation, the advice is all previously unvaccinated children require 2 doses 4 weeks apart. However, there is evidence of adequate efficacy after 1 dose of LAIV in healthy children. So in Ireland, NIAC recommends 1 dose for healthy children. In the UK and Finland, they've also recommended 1 dose for healthy children. So for children aged 2 to 8 years old who are in a medically at-risk group, who've never had any influenza vaccine before, they require 2 doses 4 weeks apart. Any child not in this group requires 1 dose. So this is children aged 2 to 8 who are in medically at-risk groups who have had any influenza vaccine before only require 1 dose. Children who are 9 to 17 who are in a medically at-risk group, whether they've had any vaccine before, any influenza vaccine before or not, only 1 dose is required. And then for any healthy children aged 2 to 17, they only require 1 dose. Next slide, please. Thanks. So regarding administration, it's given in a divided dose in both nostrils. So 0.1 milliliter is given in each nostril. There's a dose divider clip on the applicator, which allows for the administration of 0.1 mils in each nostril. The child just needs to breathe normally. There's no need for them to actively inhale or to sniff the vaccine. Thanks. The next slide, please. And there is a video of how to give this vaccine that you can find on the HSE website at that link. The next slide, please, Cría, thanks. So regarding contraindications, contraindication to LAIV is anaphylaxis following a previous dose of influenza vaccine or any of its constituents. This is except for ovalbumin, which I'll talk about in a second. Another contraindication is for anyone with severe neutropenia, an absolute neutrophil count less than 0.5, to avoid an acute vaccine-related febrile episode. This does not apply to those with primary autoimmune neutropenia who can get the flu vaccine unless there are other contraindications. Usually, good idea to get specialist advice for in this case. So another contraindication would be for those on combination checkpoint inhibitors, such as ipilimumab with nivolumab, because of a potential association with immune-related adverse reactions. Next slide, please. So some more contraindications are in a child with asthma, if there's an acute exacerbation of symptoms being increased wheezing and or additional bronchodilator treatment in the previous 72 hours, or someone with severe asthma on regular oral steroids, or who have had a previous ICU or critical care admission for asthma. The advice here is to seek specialist advice for these children. If for a child on significant immunosuppression due to disease or treatment, children who live with people who are severely immunosuppressed, such as post a stem cell transplant, contraindicated if there is concomitant use of aspirin or salicylates. If there is influenza antiviral medications given in the previous 48 hours, contraindicated in pregnancy, post-cochlear implant until the risk of a CSF leak is resolved. Specialist advice is required here, and contraindicated in those with a cranial CSF leak. So QIV should be given if LAIV is contraindicated, obviously unless QIV is also contraindicated. So the next slide, please, thanks. The following are not contraindications. So someone with asymptomatic HIV infection, or children receiving topical or inhaled corticosteroids, low-dose systemic corticosteroids, or children on replacement therapy corticosteroids, for example, if they have adrenal insufficiency. So the next slide, please. Then some precautions around giving LAIV is if there is an acute severe febrile illness, the vaccine should be deferred until they're recovered. Then regarding egg allergy, NIAC has advised that LAIV has a very low ovalbumin content of less than 0.024 micrograms per dose. So it can be given to children with a confirmed egg anaphylaxis or egg allergy in a primary care setting or school setting. The exception, however, is any children who have required ICU admission for a previous severe anaphylaxis to egg. These should be given LIIV in hospital. LIIV is the preferred vaccine for children who have required admission to ICU for a previous severe anaphylaxis to egg, as the intranasal route is less likely to cause systemic reactions. It should be given in hospital. Next slide, please. Thanks. So after vaccination, paracetamol or ibuprofen can be given for common side effects. It's advised that aspirin or salicylates are avoided for 4 weeks unless medically indicated. Ray's syndrome has been reported after salicylate use during wild-type influenza infection, and avoid influenza antiviral medication for 2 weeks. Next slide, please. So then just regarding storage of the vaccine, influenza vaccine should be stored at 2 to 8 degrees Celsius. You should take the LIIV vaccine out of the fridge when you are sure you're going to use it. Keep the pre-filled syringes in the outer carton to protect them from light. The vaccine is sensitive to heat and cold. Heat speeds up the decline in potency of most vaccines, reducing their shelf life. They should not be frozen. If a vaccine has been frozen, it should not be used. Freezing can cause increased reactogenicity and loss of potency for some vaccines. It can also cause hairline cracks in the container, meaning that the contents can become contaminated. Next slide, please. Thanks, Cría. And then just regarding ordering and delivery schedule, they can be ordered from the HSE National Cold Chain Service using the online ordering system at ordervaccines.ie. During the flu season, flu vaccines will continue to be delivered to sites fortnightly. There are no ordering limits for LIIV. Please order what you need as you go and check your NCCS calendar for order cut-off deadline for each cycle. Next slide. Yeah, so we're coming to the end there. As always, if you have any questions about any of the vaccines, you can email us at immunisation@hse.ie. And I'll just hand back to Aparna there.
Great, thank you very much, Eimear. So thank you all for coming this afternoon and spending your lunch hour, I suppose, on our Lunch and Learn webinar. We're hopefully going to be having another one next week, particularly on, talking to our care workers to increase uptake in health and care professionals. So hopefully you'll join us then as well. But as I said before, thank you to all our speakers, Dr. Eimear Hayes, Dr. John Foster, Dr. Patrick Kelly, and also to Cría Dowling, and also to Dr. Alice Quinn and Dr. Tom Barrett for our SMOs who've joined us on the chat there, answering some of our queries there. We will make this presentation and the recording and the resources that we mentioned available on our immunisation.ie website. So thank you very much for your time today. Bye.